take the recorded video at the end. So I would like to request Dr. Ramanuj to give his talk on when and how to intervene in traumatic macular holes. Dr. Ramanuj is an associate professor at AIIMS Rishikesh, and he's a dear friend of mine, and he'll be talking on when and how to intervene in traumatic macular holes.
Thank you, Dr. Devesh, for kind introduction, and thanks for including me in the part as I see. So I'll be talking about when and how to intervene in traumatic macular holes. Slides are not moving. Slides are not moving. Yeah. So traumatic macular holes are overall the incidence varies between 1 to 9% and is generally more commonly associated with closed globe injuries as compared to open globe injuries. The functional outcome of traumatic macular holes may be unpredictable, and there are no randomized controlled trials on traumatic macular hole treatment, and there is lack of established guidelines. So the possible etiopathogenetic mechanisms which are responsible for TMH include direct macular rupture or post-contusional cystoid degeneration, and it could be due to anteroposterior vitreous traction, or in cases of thermomechanical disruption in case of post-Nd:YAG laser or even iatrogenic laser used for recreational purpose. So how these traumatic macular holes differ from idiopathic macular holes? They are generally more elliptical, not exactly round, they are more eccentric, and they generally have a larger base diameter with thinner average retinal thickness. So some of these traumatic macular holes do close spontaneously, and if we look at the literature regarding the case series, the mean age is generally between 21 to 30 years of age, and they have a wide variation of closure rates, right from 10 to around 70%, and the closure time after injury varies from 1.3 to 9 months, but most of these would close within 3 months of the initial trauma. So what are the factors that favor spontaneous closure of these macular holes? Young age, smaller minimal diameter of the macular hole, and absence of PVD at the time of presentation. So intraretinal cyst, presence or absence of intraretinal cyst is controversial with respect to traumatic macular hole. While some studies have mentioned that there is a good prognostic factor, some others tell that this might be a worse prognostic factor. The current standard surgical management is same as in idiopathic macular hole, like PPV, induction of PVD, dye-assisted ILM peeling, fluid exchange, followed by gas tamponade. The timing of vitrectomy is controversial, but surgical intervention was reported as less successful for closure if it is elected after 3 months. So coming to the peeling techniques, you can have conventional ILM peeling techniques if it's a small or less than 400 microns, and you can go for inverted ILM flap techniques for large or extra large macular hole, and there are variations which are used like temporal flap, cabbage lip inverted flap, or inverted flap with extra manipulation. So coming to the case-based scenario, this is one of the patient, 26-year-old patient who had a blunt trauma to the right eye with water ball. At presentation, we can see commissuretiny, a full thickness macular hole, pre-retinal bead, multiple choroidal ruptures. So we opted for 3 months of observation, although the visual acuity improved marginally, but the traumatic macular hole persisted. So if we look at the minimal linear diameter is more than 400, and the base diameter is more than 1000 microns, and all of the indices of the macular hole parameters are worse prognostic factors. So we took up the patient for vitrectomy, standard 23 gauge Parts-Lange vitrectomy. After doing core vitrectomy and PVD induction, then BVG helps in contrast enhancement, and you start in an inferior paramacular area with the pinch and peel technique for ILM peeling. So generally I do it in 2 circles, one inner circle with some foveal hinge of the peeled ILM, and sometimes you might get one of the flap might get detached, especially in the region of choroidal rupture where it is strongly attached, and then you try to peel in the outer circle. The exact ILM peel area is debatable, but most of the surgeons would peel at around 2 disc diameter from the center of the fovea. And it's important that you just place it very gently, but you don't try to stuff it within the macular hole. This is followed by fluid air exchange and gas tamponade. So post-operatively, we can see that there is a type 1U type of closure, and the patient visual acuity improved also subsequently. So this is a second patient who is a young male patient who also had a blunt trauma with ball 1 year back. He came to us pretty late after 1 year, so it was initially managed elsewhere with conservatively, and we can see again the base diameter is more than 1000 and the minimum diameter is more than 600. The patient's indices are poor, so we planned for 23 gauge Parts-Lange vitrectomy. And after standard steps, triamcinolone acetonide assisted PVD was induced, and following that, BVG dye was used. But contact period of BVG dye in my cases, I generally limit it to the 30 seconds, and we start in the inferior paramacular area gently, and I use it in 4 petaloid patterns and keep the hinge of the ILM towards the foveal side, so that even if you get one of the flaps get detached, you will have other flaps with which you can cause inverted ILM flap. So there are various maneuvers by you can do it, just replace it with during the fluid air exchange. You may not peel the complete 360 degree, you can just peel in the temporal 180 degree, so that you can preserve the papillomacular bundle in some cases. And once you have peeled in the inner circle, you can try to complete it within the outer circle, approximately 2 inch diameter area, taking care not to damage the underlying retinal nerve fiber layer. So the peeling of the ILM can be started with Finis loop also, and once you have done that, you can use it with a very low suction, high cut rate. You can trim the edges of the ILM and very gently place it over the macular hole, followed by fluid air exchange and gas tamponade. So again, this patient had a good type 1 closure, and initial OCT, you can see also that the ILM flap is also there. So how much ILM to peel? There is no consensus on the optimum peel weight. There is wide variation, right from 0.5 to 3 disc diameter. Most will peel around 2 disc diameter. And optimum peel can preserve the ILM for future also in case you have a refractory macular hole. Larger peel would have a chance of more NFL damage. OCTA have shown that lower vessel density in deep retinal plexuses in area of ILM peel, but multifocal ERG shows no decrease in retinal sensitivity in ILM peeled areas. And overall, there is equal visual acuity outcomes regardless of ILM peel weight, as long as it is sufficient to allow the macular hole closure. Sometimes you may require PFCL as a resort to peel ILM peeling. So in this patient, initial steps are same. I have peeled the ILM in the 2 circles and then trimmed the edges of the ILM, then gently introduced PFCL under low infusion pressure, and then you just try to place the ILM under PFCL over the macular hole. It is especially useful if you have a commotio retina, and if you feel that peeling the ILM is difficult, then you can also use this under the PFCL. And once the PFCL is there for around 45 to 50 seconds, then you can remove the PFCL, and the ILM nicely stays back over the macular hole area. And you can do the fluid air exchange followed by completion. This is another case which has a 21-year-old male who had a blunt trauma with cricket ball 4 days back, presented with post-traumatic posterior giant retinal tear with total retinal detachment with a full thickness macular hole. And this patient also, we introduced PFCL and peeled ILM under the PFCL, especially taking care because the posterior edge of GRT was quite close to the fovea, and we got a good closure of the macular hole. This is the GRT edge, but unfortunately this patient, we initially introduced gas tamponade, but following gas had a redetachment, then we did oil tamponade and ultimately did well with after silicone oil removal with also the macular hole was closed. So gas tamponade is preferred over silicone oil tamponade in macular hole because of higher surface tension, and reported closure rate is although higher with gas tamponade as compared to air tamponade, but now currently it has been shown that air tamponade is also okay particularly if it has a medium or small sized macular hole. Silicone oil tamponade have been reported to be if the patient is a very, very large macular hole or particular difficulty in positioning or patients with concurrent retinal detachment. Various adjunctive therapies in the form of TGF-beta2, platelet concentrate, autologous serum have also been used. So these are the literature review of PPV outcomes for traumatic macular hole, which shows the anatomical success rate in the tune of, currently with inverted ILM flap, it's more than 90%, close to the 100%, although the functional success do not match as compared to the anatomical success, but it varies widely from 25 to 90%. And this is a recent meta-analysis which showed over 1,000 times that pooled event rate of TMH closures and visual acuity improvement rate is significantly higher in Parsonage vitrectomy group as compared to spontaneous closure group. So decision of whether to operate or observe is controversial. Overall, the rates of TMH closure and visual acuity improvement were significantly higher with PPV than in the observation group. However, PPV may be deferred for 3 months in select subset of patients, especially if you have a young patient with smaller minimal diameter and there is no PVD at the time of presentation. PPV, ILM pill or inverted ILM flap technique and gas tamponade are most common and effective surgical maneuver. The visual acuity may be unpredictable. Final visual acuity depends less upon the size of the hole than upon the degree of photoreceptor and RPE cell disruption. Thank you for your patience here.
Thank you, Dr. Ramanuj, for the comprehensive overview, and I think it was a absolutely wonderful presentation covering all the aspects. So quickly, I'll ask just one question: that do you consider macular hole indices in your treatment decision, whether you want to intervene or what type of surgical intervention you want to do?
No, generally not. I consider mainly the minimal diameter that is important and height, but otherwise,
do you
particularly
modify-
especially for traumatic macular hole, this doesn't matter. Although it might be true for idiopathic macular hole, not for traumatic macular
So
hole.
you perform ILM peel with flap in majority of your cases?
Yeah,
or
I do pill ILM, only ILM pilling if it is less than 400 microns minimum diameter, but if it is more than that, I do ILM flap.
Do the edges of the hole, how they look on your OCT, modify your decision to wait or operate? Whether they are raised, whether they are flat, do
Yes,
they modify
if
your
it is
decision to wait or
probably if it is flat, then you can wait for some period, but if it is raised, then it would be good
So-
for go.
in the paucity of time, I'll
Yeah.
invite our, thank you, Dr. Ramanuj. I'll invite our next speaker, Dr. Simar Rajan Singh, and he is working as assistant professor at PGI Chandigarh. And he'll be speaking on how to deal with post-traumatic giant breaks and retinal detachments. Over to you, Dr. Simar.
Thank you. Thank you, Dr. Devesh, for having me here, and thank you, AS, for this opportunity. So I'll be talking on post-traumatic giant breaks and retinal detachments. Traumatic retinal detachments can vary anywhere from 6 to 19% of the total retinal detachments that we operate. Majority of cases are rhegmatogenous, but tractional can also be present. Closed globe injury is the commonest cause of traumatic retinal detachment, but open globe injuries tend to cause more retinal detachments. But closed globe injury, as it is more commoner than open globe, so hence you get more retinal detachments. You get to see more retinal detachments post closed globe injury. Overall, this data should be taken with a lot of pinch of salt because the studies on traumatic retinal detachments are very few, less than 10 actually in the literature, and none of them are randomized or any prospective studies. Most of them are retrospective. So this is just some data to give you an idea of what it is. On the timing of intervention, there is no doubt that primary repair should be done as early and as possible. We heard the principles of that within 24 hours, preferably. Timing of the VR intervention is debatable. Many cases may not develop retinal detachment initially, but they could have a retinal break. Retinal detachment could develop later once there is a posterior vitreous detachment. A good clinical examination is paramount, including ultrasonography that is done by yourself, not by your technician or anybody. Once you have seen the case, you have to do it yourself so that you can assess that, yes, where the impact of the trauma could be, you could assess that site yourself. Early intervention, less than 7 days, may be associated with lesser PVR and better retinal anatomy, but it also runs the risk of going into a hot eye, more intraoperative complications, increased inflammation. So you have to kind of find the balance once you see the case, and there is no consensus on this. So you can see this is the review that is available, which lists out a few of those studies that are available, and all types of intervention were done in this. There is no recommendation on that. It's on a case-to-case basis, as is with most of the trauma. And the success rates in these cases are mostly to the range of 50 to 60%, much lower than what we would expect with a normal rhegmatogenous retinal detachment, where we can get success rates over 90% nowadays. And you have to be aware of the complications. A lot of these cases may have hypotony to start with, but once you fix that retinal detachment, that IOP is going to go up. The trauma side effects are going to come in. So the patient counseling should be considered accordingly. Also, cataract formation rates are higher if it is not present at presentation, and along with PVR redetachment rates going into phthisis, all those complications are higher in trauma cases. So I'll just come to the cases. This was the 22-year-old male with blunt trauma, fist injury during a fight. One of the simpler cases to do, you can see almost a giant retinal dialysis temporally with a retinal detachment involving the fovea. So these cases, a scleral buckle works very well. You have a good media clarity, you have a good view. Excuse me, sorry.